Hi, Amanda. I'm Megan. I'm going to be one of your student physical therapists working with you today.
Hi.
Hi. So, thanks for meeting with us. What I'm going to start first with is just asking you a few questions. So, can you just explain a little bit about what's bringing you in today?
Sure. So I have always had headaches like on and off throughout the years, but just recently I started getting more. And I've also noticed that I've been getting more pain like all down my neck, like even up to like right on top of my shoulder. And I have noticed it mainly because I'm doing painting at my house. And I'm righty, so I am constantly just doing this. And I notice like with my doing that so much, like that's when my headaches get worse and I get more pain.
Okay. How long ago did they start getting progressively worse?
Like about 2 weeks ago.
Okay, that's around the same time that you started repainting the house?
Right, yeah, exactly.
Okay. So when these headaches come on, about how long do they last?
It depends, like it comes and goes. Like once I stop doing the activity, like I notice that it, lessens, and like I'll take aspirin or something and it'll help, but it takes a little time.
Okay. Are you taking any other medications for this?
No, that's it.
Just aspirin. Have you noticed that the intensity of the headaches is getting worse as well, or they're just coming on more often?
Yeah, like a little of both. I would say they definitely they come more often, like when I'm working on the house. And that the headaches, yeah, they're not, I would say, the same as they've been in the past.
Okay. Have you had any accidents or falls in your recent history that we should know about?
Nope, no.
Okay. And when these headaches come on, do you have any differences in your vision that you notice?
No.
Okay. And any like nausea or skin rashes coming on with them?
No.
Okay. It's all good to hear. The pain, let's go a little bit into the pain in your neck, right? You've been saying it's kind of on the right side, right?
Yeah.
So kind of your neck and down into your shoulder a little bit.
Right.
How would you describe that pain?
Say it's like a achy pain, and then it like throbs a little bit.
Okay. Any numbness and tingling down into your arm with
No.
that? Okay. So, do you get any, when these headaches are coming on, do you get any kind of numbness or tingling in the face?
No.
Okay, that's good. So, how would you rate the pain on a scale like 1 to 10? Let's start with the headache pain.
I would say it's, I don't know, probably like an 8 out of 10.
Okay, it's at worst, it's an 8 out of 10.
Yeah.
You're
After aspirin, or if I like am resting, it goes down to like maybe a 3.
So the headaches get worse when you're doing your painting, right? That's when they come on?
Yeah.
Okay. Do they come on at all on their own when you're not moving around?
Not real. No, not really.
Okay, so they're kind of always associated with moving your shoulders or your neck around.
Yeah.
Okay. Do you feel any pain down into your back at all? Does it radiate anywhere else outside of the neck?
Not really. Just like kind of like on my like upper back, like right here.
Okay.
Not like down my back, no.
Okay. Is there anything else that you do besides the painting that either makes the neck pain worse or the headaches coming on?
Not really. Not that I can like pinpoint.
Okay. Is there anything you do to make them better besides taking aspirin?
No, just not doing anything.
Okay. Do you notice any time of day that it's worse, either in the morning or at night? Or is it really just activity dependent?
Just really when I'm doing the painting.
Okay. Is there anything else that you're not able to do? Say anything with work or any other activities that you were able to do before?
Not really. Not that I like need to be doing it, I guess.
So really just to get you back into painting.
Yep, got a big house.
House. Oh, got a big house to repaint. A lot of painting. Any good colors?
Yeah.
Okay, good. Just a little bit more questions about anything in your past medical history that you should know about that might be related. I know you said no falls. Anything else?
No.
Okay. Any family history of headaches or neck pain that you know of?
I mean, my mom gets headaches sometimes, but hers happen just randomly.
Yeah, don't we all? Unfortunately. Any other like past orthopedic history in terms of any surgeries, anything like that?
No.
Okay. Have you seen a doctor for this neck pain?
No, I haven't.
They're coming too. Okay, thank you for choosing us. So, have you had any imaging?
No.
Okay, just want to double check. What specific motions that you do cause you the pain in your neck or that headache pain?
Pretty much when like I bringing my arm overhead for like a long period of time. Like
Okay.
when I'm like doing the painting or whatever, like I get using my right arm the most.
Okay, so any overhead motions with your arms really brings it on. Any kind of movements of the neck, any rotation, kind of bending side to side, anything like that bring on the headache pain?
Just looking up.
Okay, so bringing the arm up overhead and looking up.
Yeah.
So it brings it on. Okay. Before all this pain came on, were you kind of independent? Were you able to do the house painting and everything at work okay before you started getting these headaches?
Yeah. I would say now with this happening, like I find like by the end of the day, like at work, like I'll also just like I'll have more pain than I would usually, even though like it really happens like after like I've been painting for a while. But I'll just notice it's like more sore than I would be.
Okay, what do you do for work?
I'm an occupational therapist.
Okay, it's a great career. So a lot of hands-on work and moving around.
Yeah.
Okay, so you find it the same when anytime you have to kind of lift overhead at work, it brings it on?
Yeah.
Okay. Thank you for answering all those questions, Amanda. So now I'm just gonna bring you over to my colleague, Alan, and he's gonna do a few screens on you and start kind of doing a little bit of hands-on work to see what's kind of going on in your neck, okay?
Okay, thank you.
Thank you.
So through the assessment, we found a couple of things that might be contributing to the patient's neck pain. She complained of having neck pain when she raised her arm overhead and looked up. Through the observation, she was a little bit tender to touch along the upper right trap area, a little bit of hypertonicity found in that area as well. When Alan palpated along C2, C3, she was a little bit tender. She felt a little bit of tenderness there. Again, with that raising her arms overhead, she felt a little bit of pain in the back of the neck. The strength assessment seemed pretty good for the most part. She did show a little bit of weakness in serrated anterior, so that's why we threw in a little bit of serrated anterior exercises towards the end. It's hard to tell during the video, but she did have a little bit of an extension give when she looked up, and we did test the deep neck flexors, which tested pretty weak. So that's why we decided to throw in a little bit of deep neck flexor exercises in there. All our neurodynamic assessments, such as the slump test and the upper limb tension test, were negative as well. During our pavums and pivums of the upper C-spine, we noticed that she was limited in that posterior right quadrant when she rotated and extended her neck to the right. The upper T-spine, lower C-spine show a little bit of issues with extension or closing. So she's sitting in that forward flex position, so she's having a little bit of issues with the closing of the upper T-spine. Our combined motion assessment again showed she's limited and painful in the posterior right quadrant. Our differential that we showed here, you see Alan take the tension off of the upper trap, which showed no real significant difference, but it did help a little bit. The upper rotation of the scap proved to be one of the most beneficial findings we found. He also provided stabilization of the neck, which proved to be beneficial as well. So there's a couple of things that we chose to focus on were the upper rotation of the scap, as well as the stabilization or deep neck flexor exercises to stabilize the neck. During our treatment, we really utilized the Rackham methodology, which was the release through the soft tissue mobilization, and then the alignment through the mobilizations. For our assessment, which reproduced our patient's initial pain or complaints of headaches, led us to believe that she is suffering from cervicogenic headaches. So her pain was reproduced during certain postures, which is that forward head posture as we saw before, overhead motions of the right shoulder, as well as rotation and extension to the right hand side in the C-spine. The patient did present with hypertonicity in the upper trap, as well as the right levator scap, which attaches to C2, C3, which may be contributing to that hypomobility at C2, C3. And then you have a compensated motion at C3, C4, which we saw with that accessory glide. The upper trap hypertonicity and pain could be a global compensatory action of the upper trap muscles to try to stabilize that C-spine due to the lack of deep stabilization in the C-spine as well. When we did apply external stabilization at the neck, the patient did experience some relief, as well as the scapular assist with the upper rotation also provided some relief for the neck pain when she does raise overhead.
Hello, Amanda. My name is Tobena. I'm a part of the rehab team that you've been speaking with and working with so far. I just want to give you a little bit of insight about what's been going on with your shoulder and your neck, and then just about what our plan is to help you, okay?
Okay.
So I know that sitting during your work as an occupational therapist, you're propped up, you're hunched over a lot, and then during your painting, you're using a lot of upward motions. So what's going on actually is that upward motion that you are when you raise your arm is causing some a muscular imbalance that's occurring in the back of your neck that is kind of transitioning up into your head, causing some of those headaches that you're experiencing as well. So what we're going to do is try to get you to calm down what we call the upper trap, which we noticed had a lot of hypertonicity. So that's one of those muscles that is helping you do those shrugs. And what it's actually doing is causing what we call the levator scapular muscle to overcompensate. And that's a muscle that we really want to calm down. So as you are sitting at your desk, we want you to kind of unload that muscle to calm down that muscle. So you can put any type of pillow or armrest underneath your arm to really unload the strain that's causing in that muscle. So going into that levator scap, I want to just talk about like things that it actually does for you. So that's the muscle that also helps you raise your shoulder up, but it also helps with downward rotation of your scapula. And that downward rotation is what we're trying to prevent from happening. We actually want to encourage upward rotation of your scapula, which is why we want your upper trap, lower trap, and what we call your serratus anterior to be working together. You can think of those three muscles as the three amigos, and we want those three amigos to work nicely in conjunction so that they work together and help with your motion.
Right.
So we're gonna calm down that levator scapula so that it's not pulling your arm down as opposed to helping. We want to encourage you lifting up your arm. So we're gonna really retrain that lower trap, which during the testing that we did during the assessment that Alan treated you for, we noticed that you had a little bit of a deficiency there. So we really want to work and retrain that lower trap to work properly and efficiently.
Sounds good.
Great. So another treatment that we're going to work on is really working on getting the muscles and the slide and glide go nice and smooth so that when you turn your neck to the right, there's nothing impeding the motion, okay? So we're going to clear that up with some of those joint modes and some of the treatment that we did earlier. So really make it so when you do turn to the right, there's nothing impeding your motion and it's a nice smooth transition.
Sounds good.
That sound like something that you're up to, something that you feel comfortable doing?
Absolutely.
That sounds great. I feel like with the rehab team that we have on board, you're going to be just fine. This is nothing that we haven't seen before, and we're very confident. You seem like you're very compliant, and we look forward to working with you, Amanda.
Thank you so much.
You're very welcome. It was a pleasure meeting you and speaking with you. I look forward to working.
Same here.